Hi and welcome back to our page. You've got a person with dementia in your service and she's refusing to stand up. It's getting worse, staff are exhausted and they've tried everything they can think of. And now they're talking about hoisting. The GP thinks it's behavioural, but you need to know, what are you actually supposed to do here? What does the law say? And what does CQC expect? And how do you keep this person safe without taking away their dignity or their rights? This is one of the hardest situations you'll face in care. And the wrong response can put you on the wrong side of both CQC and the Mental Capacity Act. So let's walk through this properly, step by step. The first thing you need to do, and this is where a lot of services go wrong, is stop treating the refusal as a problem. The refusal is a symptom, it's communication, and your job is to figure out what it's communicating. NICE Guideline NG97, Dementia, Assessment, Management and Support for People Living with Dementia and Their Carers, it's clear that behavioural and psychological symptoms in dementia should be understood as a potential sign of unmet needs. These needs could be biological, psychological, social, or environmental. So before anyone starts reaching for the hoist, you need to ask some serious questions. Is this person in pain? Undiagnosed or untreated pain is one of the most common reasons people with dementia can resist care. They can't always tell you that they're hurting, so they resist the thing that hurts. Has the GP actually done a thorough pain assessment using a tool designed for people with cognitive impairment, like the Abbey pain scale? Or have they just said, we think it's behavioural, without ruling out any physical cause? Is there a urinary tract infection? UTIs in older people, particularly those with dementia, can cause sudden changes in behaviour and increase confusion. Has there been a medication change? Some medications can cause muscle weakness, drowsiness, or low blood pressure, all of which could make standing difficult or even more frightening. The person's dementia progressed to a point where they're losing the ability to initiate movement, which is a recognised symptom in some types of dementia, particularly vascular dementia and Lewy body dementia. None of these are behavioural. All of them are medical, and all of them need to be investigated properly before you start changing the way you move this person. Once you've started asking those questions, you need the right professionals around the table, and this isn't optional. CQC's quality statement on person-centred care, under the single assessment framework, explicitly expects services to involve people in planning their care and to work with other healthcare professionals. Consider occupational therapy assessments. An OT can assess the person's physical abilities, their environment, and the equipment that might help. They can tell you whether this person has the core strength to use a stand aid, whether a different type of transfer equipment would work, or whether a full body hoist is now clinically indicated. This isn't your decision to make without a professional assessment. Also, a physiotherapy referral. A physiotherapist can assess whether the person's mobility can be maintained or improved. They might identify exercises, positioning techniques, or equipment that keeps the person mobile for longer. Taking away mobility too early by defaulting to a hoist when there are alternatives can accelerate decline. Consider GP reviews. Push back if the GP has dismissed this as behavioural without a thorough investigation. Request a comprehensive review that includes a pain assessment, medication review, bloods, and a urine sample to rule out infection. You're the person's advocate. Don't accept a quick answer for a complex problem. Mental health team referrals is also key. If the dementia is progressing, a referral to the community mental health team or dementia team for reassessment is appropriate. They can review the stage of dementia, advise on behavioural approaches, and review any psychiatric medication. Now here's where the Mental Capacity Act 2005 comes in. And this is the part that most care providers don't always get right. The MCA has 5 principles, and you need to apply every one of them to this situation. Principle 1, assume capacity. You must start from the assumption that this person has the capacity to make the decision not to stand up, even if they have dementia. Dementia does not automatically mean someone lacks capacity. Capacity is decision specific and time specific also. Principle 2, support the person to make their own decision. Have you tried everything? Have you tried a different time of the day? With a different carer, with music playing, with a cup of tea first? After pain relief has had time to work, the MCA says you cannot treat someone as unable to make a decision unless all practical steps have been taken to help. Principle 3, an unwise decision isn't the same as a lack of capacity. If this person has capacity and is choosing not to stand, that's her right. You cannot override it because you think it's unwise. That's the law. But if after a proper assessment you determine that the person lacks the capacity to make the specific decision, to understand the risks of not mobilising, to weigh up those risks, and to communicate a decision, then you move over to Principle 4 and 5. Principle 4, act in their best interest. This means a formal best interest decision, documented properly, involving the person as much as possible, consulting their family, their care team, and any appointed advocate or IMCA. You consider what the person would have wanted when they had capacity, their beliefs, values, and past wishes. And Principle 5, least restrictive option. Whatever you decide must be the option that interferes least with a person's rights and freedom. So if hoisting is clinically necessary, you document why it's the least restrictive way to keep this person safe. If there's a less restrictive option that achieves the same outcome, you must use that instead. Let's be honest. Sometimes after you've done all this, the answer is that the person does need a hoist. Their core strength has declined, the OT has assessed them, and a full body hoist is the safest way to transfer them. That's not a failure, that's appropriate care. But you need the right governance around it. You need a mental capacity assessment documented for the specific decision about how this person is transferred. You need a best interest decision recorded, showing who was consulted, what was considered, and why hoisting was determined to be in the person's best interest. You also need an updated moving and handling risk assessment completed by someone competent, ideally following the OT's recommendation. You also need an updated care plan that reflects the new transfer method with clear instructions for staff. And you need to consider whether this change amounts to a deprivation of liberty. If the person is now under continuous supervision and control and is not free to leave, which in a care home setting with a person with dementia is often the case, you should already have a DoLS authorization in place. If not, apply for one immediately. And one more thing, do not put an in situ sling on someone without going through this process first. An in situ sling, one that stays under the person all the time, can cause pressure damage, skin breakdown, and discomfort. And it's also a form of a restrictive practice. It should only be used when clinically justified, properly risk assessed, and reviewed regularly. Now, there was a follow-up question that came alongside this one, and it's an important scenario. What happens when the next of kin holds lasting power of attorney for health and welfare and is refusing to allow OT, physiotherapy, or GP referrals? This is where you need to be very clear about the law. A health and welfare LPA gives someone the authority to make decisions on behalf of a person who lacks capacity, but only decisions that are in the person's best interests. If you believe that refusing professional assessment is not in the person's best interest and that the refusal is putting the person at risk of harm, you have duty of care to challenge it. Mental Capacity Act Code of Practice is clear that an attorney must act in the person's best interest, not in their own interests or for their own convenience. If a family member with LPA is blocking assessments that would keep the person safe, that's a potential safeguarding concern. You should document your concerns and escalate it within your organisation, and if necessary, make a safeguarding referral to the local authority. The local authority can investigate whether the attorney is acting appropriately, and in serious cases can apply to the Court of Protection to have the LPA revoked or overridden. Don't simply accept the family member's refusal and leave the person at risk. That could constitute neglect, and it's your registration on the line. So let me bring this all together. When a person with dementia is refusing to stand, don't jump to the hoist straight away. Work through it properly. Investigate the cause, rule out pain, infection, medication side effects, and disease progression. Get the OT, physio, GP, and mental health team involved. Apply the Mental Capacity Act properly. Document everything. And if hoisting is the right answer, make sure it's supported by a capacity assessment, a best interest decision, an OT assessment, and updated care plan and risk assessment. This is hard work, it takes time, and it takes leadership. But it's the difference between outstanding and inadequate. And more importantly, it's the difference between care that protects someone's rights and care that doesn't. If you need help with your policies, your MCA processes, or your CQC compliance, get in touch with us at CareSync Experts. The link is in the description. Hit subscribe, leave a comment if you've been through this, and share it with your team. See you in the next one.